Hyperkalemia in ARNI patients has to be managed in a very systematic manner. First, we have to confirm whether it's a real tissue hyperkalemia or it's a pseudo hyperkalemia because of the faults in the blood collection pattern. Because of too much traumatic collection, there can be false elevation of potassium because of the RBC damage. So that needs to be correlated with the ECG or other concomitant settings like renal failure, diabetes and other, whether this patient is prone for hyperkalemia or not. If ECG and a true blood shows that there is a hyperkalemia, then that has to be managed in two scenarios. One, if it is a dangerous hyperkalemia, let's say more than 5.5 or 6, then in that case we have to manage on a little bit on an emergent scenario by stopping the ARNI, stopping the mineralocorticoid receptors if they are on, and then our age-old partner, that is insulin and glucose drip, asthalin nebulization if heart rate tolerates, then judicious use of diuretics so that potassium is excreted. If still higher, then we can use K-bind, that is K-xylate preparations along with the sorbitol or lactitol preparation so that the potassium is squeezed from the colon and thrown out. Then on a chronic basis, if the patient is more prone, in that case strictly low potassium diet, that is no tea, coffee, fruit juice, coconut waters, banana. Then concomitant issues like maybe we have to check on beta blockers causing interaction, heparin causing the interaction. So all these things has to be managed in an appropriate manner and continue the low dose diuretics so that potassium excretion is maintained via the kidneys, and then osmotic agents for the GI tract which will go on pulling the potassium from the GI tract so that 2 to 3 loose motions happens. So that can be managed on a chronic basis. The one point which I would like to highlight is if there is a Patiromer which becomes available, then hyperkalemia can be managed more confidently and more quick fashion. Last but not the least, the concomitant medicines like MRAs, ACE inhibitors or ARNIs. So all these things, whatever that can lead to hyperkalemia, must be actively sought for because hyperkalemia is a silent killer.